Our next speaker today is Stephen Richemer, MD. Dr. Richemer is a professor of anesthesiology and psychiatry and chief of the Division of Pain Medicine at the Keck School of Medicine at USC. He is a diplomat of numerous boards, the American Board of Anesthesiology with a subspecialty certification in pain management, with the American Board of Pain Medicine and the American Board of Psychiatry and Neurology in Psychiatry. Dr. Richemer is also the director of the new innovative USC online master degree program in pain medicine. And Dr. Richemer is going to talk to us about non-opioid treatments in neuropathy. Dr. Richemer.
Thank you very much. Pleasure to be here. And this is sort of a hot topic these days. Hard to open up a newspaper, if anybody looks at newspapers anymore, or see anything on the media without a lot of discussion of opioids. So I do believe opioids are problematic, not necessarily for the same reasons that you hear about in the media. And I'll discuss as we go into this a little bit why I think they're problematic. I'm not saying there's never a use for them, but not as common as we tend to use them. And I'll discuss some of the options we have for treatment for pain without opioids. Okay, first a little background on opioids. This is where they come from. This is the opium poppy. It doesn't grow in the United States, and its bud is loaded with sap that can be harvested and produce opium, and the natural morphine-like compounds all are derivatives of opium, but nowadays we also have lots of synthetics. So let's talk a little bit about why we want to even make an effort to avoid these. So this is what you may have heard about, just phrased a little differently. If two 737 Boeing jetliners dropped out of the sky every single week, what would happen? I would suggest nobody would air travel. Right? The FAA would close down all flights in America. Right? Nothing would happen until we solved the problem. Right? But this is the number of people that are dying from opioid overdose. Okay? And we're not quite there yet where we're shutting down everything until we solve the problem. Obviously, it's a difficult problem. 25 million Americans suffer from daily pain. 23 million report that they have a lot of pain. So we clearly need tools to address this. And now the question is, can we come up with tools other than opioids? But let's talk a little bit about what the CDC, the Center for Disease Control, has said about how opioids should be used. So they say for chronic pain, you always want to start with non-opioids. You always want to see if you can find non-opioid medications and why, and we'll talk a little bit more regarding this, but they say that non-opioids work as well as opioids. And there's actually growing evidence for this. That non-opioid medicines are better tolerated, less side effects. Depends a little bit which side effects you're looking at. And that non-opioids leave people functioning better in their day-to-day lives. They suggest for acute pain, meaning after an injury or a surgery, that the use of opioids should be limited to 3 to 7 days. A very laudable goal, but I don't know that we can always do that. They particularly warn about the use of opioids combined with benzodiazepines. Benzodiazepines are the drugs that are like Valium. Valium, Ativan, Xanax, clonazepam, all of these are benzodiazepines. And the mixture of opioids and benzodiazepines is particularly dangerous. Opioids have lots of side effects. They tend to cloud our thinking, make us tired, constipate, cause nausea, lots of other things too. They can make it difficult to urinate, cause itching, etc. Again, what the media is focused on is the issue of addiction and overdose deaths. But what I think is more important to at least my patients is the fact that in the long run, opioids make pain worse. And that's often surprising to people. So first, let's take a look at a very recent study, just came out in March of this year. The effect of opioid versus non-opioid medications on pain in patients. They looked at two groups, patients with back pain, chronic back pain, or osteoarthritis, significant osteoarthritis of the hips or knees. And they found that those, if you compare opioids versus non-opioids, the function was the same. And they looked at over a year. Pain intensity was lower in the non-opioid group. Big surprise to a lot of people. And the side effects, what we call adverse medication-related symptoms, were higher in the opioid group. Right? So this is, one more big nail in the coffin of opioids. Again, it's a little premature to say opioids are dead, but more and more we're beginning to realize there's fewer and fewer reasons to use them because other medicines work just as well or better and maybe have less risk. Now, as I mentioned, when I'm talking to my patients, it's relatively rare if we're talking about getting off of opioids or not using opioids. It's relatively rare that I'm discussing the issue of addiction and overdose. Because my patients, thank God, by and large, use medicines the way they should. They follow instructions. And they say, well, all that stuff doesn't relate to me. So that's not the issue. The issue that I'm worried about, and I think my patients should be worried about, is this. So let me explain this. Do I have a pointer? No, I guess not. So on the right side of the screen, that's a schematic, a cartoon of a synapse in the spinal cord. And the top part of that cartoon is the end of a nerve coming from somewhere in the body, like the feet or the hands, coming into the spinal cord, and that's the end of it, where it has to release chemicals across a little gap called a synapse to activate the next nerve, which is going to carry the pain signal up to the brain. So there's a whole bunch of neurochemistry going on there. And for the last 40 years, that's where we've been focusing our thoughts about how analgesics work. Analgesics are pain relievers. So morphine and other opioids bind to where you see the little mu in the black oval, both on the pre-nerve and the post-nerve in the synapse. They bind there, and they make it less likely that the pain signal is going to cross from nerve 1 to nerve 2. And if it doesn't cross to nerve 2, it's not going to make it to the brain. That's the good of opioids. But in the last, half a dozen years, more and more the shift of the research is leaving that synapse and going to this thing on the left, which is my symbol for the insulation of the nerves, the glial cells. And all the nerves are surrounded by different kinds of cells that support them. Not physically support, although maybe they do that too, but chemically support and sort of take care and have signals going back and forth. Opioids bind to a receptor on glial cells and activate the glial cells. And an activated glial cells dumps inflammatory chemicals onto the nerves, causing more pain. So being on opioids is like driving down the freeway with your foot on the brake and the gas pedal at the same time. Right? You're getting the braking action of the synapse, but you're stepping on the gas at the same time because you're activating your glial cells, which is causing activation of the pain-transmitting nerves. Okay, and so in the long run, this is not a scenario we want. Okay, so this is, again, just a schematic. The spidery cell on the right is the glial cell that can be activated by a signal A. It releases chemicals, what we call inflammatory mediators, affecting the D cells, the pre-cell in the synapse and the post-cell in the synapse. And what activates these glial cells? Top of the chart there, opioids. Lots of other things too, but opioids is one of the activators. So how do we avoid them? So we call the process of avoiding them opioid sparing. Opioid sparing refers to things that allow us to either use less opioid or no opioid. And basically all non-opioid medications that are analgesics have opioid sparing effect. They allow us to use less of the opioids. So it's very, very common that we'll put together a mixture of different medicines. Okay, now, polypharmacy in some circles is frowned upon, but in my world in pain medicine, it's commonly used and commonly valuable because, again, we can get bits of pain relief from different classes of drugs. And then finally, we might focus on non-drug treatments. And you heard a little bit about that earlier this morning. There are a variety of physical therapies and psychotherapies and activities that can help patients outside of drugs. Okay, so let's go over some of the classes of drugs that we might want to use. NSAIDs are the anti-inflammatories, the ibuprofens, the naproxens, Mobuks, meloxicams, there's a lot of them. And acetaminophen is Tylenol. So both of these can be used, and in many situations, if somebody doesn't have a medical problem that's going to contradict this, they can be used together. And again, they can therefore get additive pain relief. A recent study from just last year, a single dose of oral opioid versus non-opioid analgesics in an emergency room setting. Another study that showed equal, in this case not better, but equal analgesia with the non-opioids. We want, especially in neuropathy sources of pain, we want medications that alter nerve function. And so some of the biggest tools that we have are the anticonvulsant class of drugs. You're all familiar with gabapentin, Lyrica, which is pregabalin. There's many others. And the antidepressant class of drugs, duloxetine, which is Cymbalta, the tricyclic antidepressants, there's many of them. And again, we're not using these because somebody has seizures or because somebody has depression, although they might have these other problems, but we're using these drugs in this setting because of their ability to alter nerve function in a way that reduces pain. Using topicals is a growing area. Topicals tend to be safer. I can't tell you they're completely safe, but they tend to be safer. So we can use numbing medicines such as lidocaine to help with pain, although it may not help if somebody is already numb. We can use topical anti-inflammatories, and we compound other drugs such as NMDA receptor antagonists, and we'll focus on that in a minute, that pharmacies can make these compounds for us. Muscle relaxants can help. Sympatholytics can help. These are beta blockers, alpha-2 agonists. All of these can help reduce nerve activation that is transmitting pain. And then, of course, the big question is, what about cannabinoids? And I'm not going to spend too much time on that because we don't know much. There's a whole lot of hype about it, but very little good science about it. The little bit we do know is that there are two prominent chemicals within natural marijuana. One is THC and the other is CBD. THC is more psychoactive. CBD has little to no psychoactive component. They probably are both analgesic, and some people believe, again, we don't have too much science, that mixtures of the two may be the best. Generally, in the pain world, if a patient is going to try it, we would encourage them, we don't prescribe it in our center, but we would encourage them to use a CBD-rich compound that might have some THC in it, but not much. Okay, this is a big focus of a new category of medicines to treat pain. So this is a schematic of a receptor in the cell wall. So those pink things that are aligned in a row represent the lipids in the cell wall that create the cell wall. And this big cone-like thing in the middle is a complex of a calcium channel and an NMDA receptor. NMDA is a chemical name, N-methyl diaspartate. And this channel is important in regulating the activity of pain nerves. Because if that channel is open, then calcium comes through into the cell, causing the cell to start becoming hypersensitive, more reactive to pain, and less reactive to opioids. All of this tends to go together. So we would like to be able to keep that channel closed, or if it is open, to close it, so calcium isn't coming in and the hypersensitivity of the cell can either not happen or go away. So normally that channel is plugged by that red blob in the middle, which is magnesium. So in its resting state, this channel, the NMDA receptor channel, is plugged by magnesium. When pain starts, there's a change in the electrical settings of the cell which kicks out the magnesium, opening up the channel. You'll see below the red blob a purple blob, sort of a trapezoid thing there, which is a PCP molecule. PCP is a drug that you don't want to take. PCP is a strong hallucinogen. It is not a legal drug in the United States, cannot be prescribed, just like heroin can't be prescribed. But it'll plug that channel. And we do have drugs that are like it that plug the channel. The one that most people have started to hear about is called ketamine. When I bring it up to my patients, they say, isn't that a horse tranquilizer? And yes, it can be, but ketamine has lots of uses in humans, primarily as an anesthesia in the operating room. But for the last 10, 15 years, there's been a lot of research on how to use it because of its ability to plug the channel. And there's other drugs like it. Ketamine, memantine, which is Namenda, which is a drug for memory, but again, it has this ability. Amantadine, a drug that might be used for movement disorders or to treat the flu, interestingly enough. Methadone is an opioid that also plugs that channel, so there's certain values if you have to use an opioid to use methadone. And dextromethorphan, cough syrup, a particular type of cough syrup, can also plug that channel. Okay, so what are some of the forms that we would be interested in using this? So ketamine commercially only comes as a drug that's used in the operating room, IV. So all these other forms of it, we have to ask the pharmacies to put together for us. It's called compounding. So we often put it together as a topical cream or as a capsule Or for severe neuropathic pain states, we actually put people into our infusion center and they get it IV. Again, memantine, here's just some different doses, and amantadine and methadone that can be used. This is the newest kid on the block, okay? Almost ready for prime time. So Oxytocin's trade name is Pitocin. So many women recognize that because that's a drug that's given sometimes to delivery, at the time of delivery, to stimulate the delivery process. Okay, so if I put my patients on this, I have to promise them you're not going to have a baby. But the newest data is showing that this drug, which is really a hormone, when it's taken in a way that crosses the mucous membranes, so either a nasal spray or what we use is a lozenge that the patient sucks on, has analgesic properties. We've only been doing this in our clinic for about 4 months. I mean, it's really, really, really new. Most compounding pharmacies still don't even know how to put it together. So it's brand new. We're learning a lot more about it. It's almost completely free of side effects, which makes it very, very valuable. It is sometimes considered the warm and fuzzy drug because one of the things it does is it promotes social bonding. So if you use this drug, the side effect may be that you may feel closer to your significant other. Behavioral approaches, again, thinking about the non-drug approaches. Biofeedback. Biofeedback is basically computer-assisted relaxation training. And relaxation training is more than just sort of woo-woo. I mean, there's a physiology behind it. Different components. One is that when you're not relaxed, your muscles are tight. And probably outside of the skin, the most richly innervated with pain fibers part of your body is muscle. Okay, so muscles can be a major, major source of pain, often triggered by an underlying problem. You know, so there might be a problem with the spine or the peripheral neuropathy or whatever it is, and now the patient's all tense and tight, and they're just making things worse. In addition, when we are uptight, we are causing increased release of what are called catecholamines, basically adrenaline-like drugs. I shouldn't say drugs, they're parts of our body, adrenaline compounds in our body. Adrenalines activate damaged nerves. Okay, so when patients are stressed, and I ask my patients this, and many of them, when they stop to think about it, they say, yeah, when I'm stressed, I hurt more. So that's a direct chemical effect. And so if we can train our patients to relax not only mind, but mind and body, they're not going to have as high a level of circulating catecholamines. They're not going to activate the nerves, which are unfortunately damaged by the peripheral neuropathy. Excuse me. So there's other things here that can help with that kind of process. Hypnosis. Typically, our psychologists don't do hypnosis in its traditional form. They might teach the patient self-hypnosis because they want them to be able to do this for themselves. Relaxation therapies, cognitive restructuring, cognitive behavioral treatments. Okay, let's talk a little bit about how potent the mind can be in the pain game. Okay, so this monkey represents a fascinating experiment. You can take electrodes that are so fine that they will record from single neurons when implanted into the spinal cord. Okay, now, again, we don't do this on people, but you can implant these electrodes into the spine of a monkey, isolate a nerve that comes from the finger of the monkey, attach the other end to an oscilloscope, so every time that nerve fires, the oscilloscope goes blip, blip. So now you shock the finger of the monkey pulls away its finger, oscilloscope goes blip, blip. You do this every day for a few weeks with one added piece of information. 10 seconds before you shock the monkey, you give it a red M&M. Right? Red M&M, 10 seconds later, shock the finger of the monkey pulls away its finger, oscilloscope goes blip, blip. After 3 weeks of doing this, you give the monkey the red M&M, and 10 seconds later, you do nothing. What happens? Definitely the monkey pulls away its finger. That's not a big surprise. The big surprise is the oscilloscope goes blip, blip. The oscilloscope, which is recording from a nerve that comes from the finger, fired. Okay? So we have the ability in our brain to send down inhibitory and facilitatory signals to our spinal cord. So the brain is sending down signals basically to the monkey's spinal cord saying, get ready, get ready, get ready, get ready, until it fires. Okay. And I think all the other doctors in this group experience this if we have patients that we do repetitive procedures on. Something as simple as a trigger point injection that I might do repetitively on a patient, the day comes that I wipe their skin with alcohol and the patient goes, ow! I didn't stick you yet. Okay, but they felt it, the nerve fired. Physical therapy, tremendously important. When something hurts, what's the first thing we do? We stop moving it. If a lot hurts, we go to bed. These are basically the worst things we can do. Okay? You gotta use and move your body in order to keep it working and not hurting. If I told all of you here, you know what, go to bed for a week, it might sound great for a little bit. By the end of the week, I can guarantee you're hurting. You heard a little bit about there's other techniques such as nerve stimulators that we can implant into the spinal cord or sometimes under the skin on peripheral nerves or near peripheral nerves. These can be useful. As you heard about from Dr. Lewis, they have to be trialed, right? So we always would do a 1-week trial to see if it's working for the patient. In our center, a semi-new technique is doing it even for facial pain. This is one of my patients who I implanted this about 5 years ago. And still now, 5 years later, she's still having 75% relief, which is pretty good for something that couldn't be treated before. So what's the overall strategy? We want to do medical treatments, we want to do therapies, physical therapies, occupational therapies, psychotherapies, and when we put it all together, our patients look like that. Okay, so I want to just end on a note that, again, we are currently in a mess of a situation. Lots of 91 Americans dying every day from opioids. 25 million Americans still with a lot of pain. In a survey from about 7 years ago, only 4 out of 104 medical schools in the United States have a mandatory course on pain. If you look at other professionals, nurses, physical therapists, psychologists, nurse practitioners, they almost have no education in pain medicine. National Pain Strategy is saying this is one of the biggest flaws in American medical healthcare education. Institute of Medicine basically said the exact same thing. I'm happy to say at USC we're trying to do something about it. So we've opened up a program, an entirely online program, open to any clinician. If there's clinicians here, I hope you will come and visit us at painmed.usc.edu or mail us, because we are offering a master's degree in pain medicine to any clinician, online or a certificate 1-year program. So we hope we can make a difference and improve the way that pain is treated in America and maybe even in the world. Thank you very much. I think we might have a minute for questions. Yeah. Any questions? Yes, in the back.
I appreciate your presentation. I do want to let you know, though, that not all the people who die from opioids come from the opioids. There are illegal opioids, and we even had to get the people to correct that. Also dealing with sickle cell. When it comes to sickle cell, the CDC said, leave them alone. But yet our hospitals out here created so that we have the lowest life expectancy out of the nation here in California. So I do want to work with you. You said something that was so powerful, but it's the things that our hospital lists and nurses do, and they stress patients. They stress them to the point that they create a need for them to stay in the hospitals longer. So I definitely want to get with you because we definitely want to change that, and we can change it together.
Thank you. Thank you. Hopefully everybody heard that. Just to address that issue of who's dying from opioids, as I said, 91 Americans are dying every day. Of those 91, 55 are related to prescription opioids. So the others, that's still a big number, are completely illegal opioids, but it's a big number from prescription opioids. Clearly we have problems with treating diseases, the pain of diseases like sickle cell. And it's one of the sort of crimes of modern medicine that the research hasn't focused there well enough to give us the non-opioid alternatives. Clearly we need to be able to do that. Yes, in the back there.
How do we fix the narrative? Because along with the want to change this, patients are being shamed, and they're being shamed by doctors and nurses, and people are afraid to get help now. I have a friend that actually has a completely different fake identity online for their Facebook because they have been shamed so much by their doctors and nurses and family that they can't even present themselves as who they are. And it's really hard on us as patients to be treated like we're a street addict in Skid Row versus somebody that has no quality of life without the opiate. So how do we change that narrative so that we're not shamed all the time?
That's a great question. The question was, how do we change the narrative where the issue of avoiding opioids is put in the context of making the patient feel ashamed? So a few thoughts. One is I partially blame the media for that. The media has focused on addiction and death. And as I said, I think that's wrong. I mean, clearly a lot of people are dying and we have to address that. But for most of you, that's not the issue. The issue that I'm concerned about is that in the long run, we may be making your pain worse. The other issue that we got to remember is 10 years ago, I would have stood up here giving you a very different story. Right? We didn't know what we know now. Doctors were much more free to prescribe opioids, okay, and often encourage patients to use opioids. It's not the patient's fault. It's medicine's fault to a large degree. Now, we can go back and look at why that happened, where the pharmaceutical companies complicit in that, and there's a whole story there. But I think the way out of this mess is education between doctor and patient and working together to try to find a better approach. When I am working with my patients to take them off of opioids, it's a slow process. It's not like, hey, we're going to stop this tomorrow. It's like, hopefully over the next 6, 12 months, we can wean you off, but as we're doing that, we're replacing it with treatments that hopefully will work better. So it's got to be a collaborative process. Okay, so with that, I think we need to stop. And really appreciate being here. And I hope everybody finds this useful, and good luck with improving.